Good morning. The topic is fractures of the both bone leg. So any fracture is a discontinuity in the alignment of the structural continuity of the bone. Any fracture is always associated with the soft tissue injury. Today's topic, both bone fracture, is the most common fractures associated in the adult, especially in the young male adults. Most common age group is around 15 to 30 age group, most commonly associated with the high velocity road traffic injuries. In female, both bone fractures are uncommon, especially in younger age, and more common in the older age. So what are the causes? The main causes road traffic accidents in India, mostly injury. Second is stress fractures in occupations like the armies or any repeated sports. Repeated stress to a particular point causes a stress fracture of the tibia. Pathological is another cause, but it is more common in the old age where there is fractures associated with multiple myeloma and lung cancers and others. In secondaries, the most common tumor, and this pathological fracture usually associated with the tumors. So what is the difference between a new fracture and a pathological fracture is that in pathological fracture there is a pain preceding the fractures. So direct force, indirect force is the mechanism. Direct force is a direct injury over the leg. In other words, an impact directly over the bone. In indirect force, that's a twisting injury. The twisting injury resulting in the fractures. The indirect forces are twisting, bending, compression and tension forces. Stress fractures or fatigue fractures, as I mentioned earlier, is a repetitive stress causing to a particular point of the bone. Pathological fracture is a fracture associated with the secondaries or mets. In tibia or fibular fracture, there are certain types of fracture. One is transverse, oblique, impacted, spiral, comminuted and compression fractures. The same fracture in pediatric, it is either green stick or plastic deformation. In pediatric also complete fracture is possible, but most commonly it is green stick or plastic deformation because one of the either bone is usually intact. So what are the fracture types? These are the pictures showing the oblique, comminuted fractures, spiral fractures, compound fractures, simple and transverse fractures. So in both bone leg, a peculiar concept is that it is the most common fracture associated with the open injury. Other fractures can also have open injuries, but this both bone leg is the most common and the most prone for open fractures because it is the lower limb that is directly exposed to any bumper injuries or fall or direct blows. So in a fracture, how to assess the quality of fracture is what is the translation between the fragments, what is the angulation, what is the rotation, is there any shortening or lengthening. Based on this, we can decide how to manage this fracture. So in translation angulation, in a pediatric population, it is a very more critical because when you are treating conservatively, we have to accept a certain angulation translation. For example, 5 mm of varus valgus, 10 mm of anterior posterior translation or angulation, and 5 mm of translation is acceptable. More than that, we have to operate. As for any other fractures, there are 4 stages of healing such as hematoma, inflammation, repair, and remodeling. Okay, this is the stages of hematoma, inflammation, that is of formation of soft and fractures of the leg. What we have to see is what is the fracture exact location. It could be both bone leg. Most commonly it is tibia. Fibula is usually conservatively managed, but it can also be need to be fixed. But most commonly we are discussing about the tibia. What is the type of fracture? What are the causes? Healing. Healing usually depends upon the whether it's open or closed fracture. It is a comminuted or simple fracture. It is a transverse or oblique fracture. Mechanism is a different mechanism was important because in high velocity injury you need to go for a plate fixation or a bicolumn fixation. It is a triangular bone with two side slopes on the medial and lateral end. If there is a comminuted fracture, we have to put plate on either sides. There are numerous classifications. The most commonly accepted is the Sherny classification, and for open injury it is the Gustello-Anderson. Sherny is where you have a fracture of the both bone legs or shaft of tibia with the associated mild to soft tissue injury. It is grade 0 with a small soft tissue injury, with grade 3 being extensive contusion and internal crush, that is impending compartment. This is a Gustello-Anderson classification based on the open injury and the size of open injury, amount of periosteal stripping, amount of contamination, and how much soft tissue cover is required. Usually type 1 being the very puncture wound, and type 3A B requires external fixation with in 3B it requires soft tissue coverage. So essentially you have to take a radiograph AP and lateral view assessing the one joint above, one joint below the fractures. Associated injury, most of the fractures there will be vascular or neurovascular injuries, especially in an open fracture. If there is a vascular injury, it is termed as grade 3C. Other associated injuries, it could be a floating knee. For example, the tibia fracture will be usually associated with a femur fracture. We have to assess other joints, and also foot injury or ankle injuries also should be associated. So both bone fracture, as common as it is associated with open injury, it is also common that there is a chance of compartment syndrome, because it is a direct impact injury. And compartment syndrome, when the compartmental pressure rises more than 15 millimeter, usually there is a compartment syndrome. For compartment syndrome is an emergency situation where you do a fasciotomy and stabilize the limb length with an external fixation. So there are 4 compartments. The one is the anterior, the other one is the lateral, the deep and superficial posterior. In a compartment syndrome, if it is impending or a full-blown compartment, you have to do a fasciotomy, releasing all the 4 compartments. So fasciotomy, there are 2 techniques. There is one incision 4 compartment release and 2 incision 4 compartment release. Usually in an emergency procedure, it is always preferred that you do a 2 incision 4 compartment release. What is the objective? You have to minimize the soft tissue damage. We have to hold the fracture in alignment, minimize soft tissue damage, also mobilize the joints. In closed tibial fractures, non-surgical management is very rare, because usually it's a weight-bearing joint and long immobilization is always disadvantaged. So only contraindication for surgical fixation will be any comorbidities, old age, or already bedridden patient. Otherwise, usually the management is by intramedullary nailing. In a complicated or comminuted fractures, you usually plate. In an open injury, we usually do an external fixation, and also if we are doing a fasciotomy, you do an external fixation. So as I previously said, it's a less than 5-year varus valgus, 1 centimeter of shortening and 10 degree of procurvatum recurvatum. Even though this is a theoretically given, we usually operate for the lower limb fractures. Surgical option is intramedullary nail, ORF plating and external fixation. Conclusion is that it is a common fracture and usually operated. Closed fractures can be in pediatric can be treated with a cast. Unstable fractures or any fracture of the adult that has minimal displacement should be treated with a preferably intramedullary nail. In rare cases, we usually operate with a plate. Non-union, malunion infection and fatigue fractures are the most common complications. These are the symptoms. Thank you.